What if the very air you exhale held a secret language about your health? I mean, not just whether you've had garlic for lunch, but, profound insights into diseases like diabetes or maybe even lung cancer. It sounds almost like a whisper from the future, doesn't it? But the reality is, our breath is this complex cocktail of chemicals, a hidden messenger system. And scientists are now actually learning to decode it with, well, astonishing precision. Today, we're embarking on a deep dive into the fascinating world of the electronic nose, or e-nose for short. It's a non-invasive technology that honestly promises to revolutionize how we screen and diagnose some of the world's deadliest diseases. We're talking about a future where a quick, simple breath could tell you more about your health than maybe a whole battery of traditional tests.
And that's really important because this isn't just about convenience. It's about tackling some really critical, long-standing limitations in our current diagnostic methods, especially for widespread diseases like diabetes and lung cancer. Take diabetes, for instance. The gold standard tests, fasting plasma glucose or the oral glucose tolerance test, they all rely on monitoring blood glucose. And while they work, they are inherently invasive, often uncomfortable, and they can impose a pretty significant physiological and even psychological burden, especially for patients who might need multiple checks every single day. I mean, think about the discomfort of repeated needle sticks, the cost of the test strips, the whole logistical hassle. And this discomfort, this hassle, well, unfortunately, it can actually discourage people from even getting screened in the first place, which allows the disease to just progress silently, unchecked, leading to much more serious complications later on. Lung cancer, well, that presents an even more stark, more urgent challenge.
Conventional diagnoses, things like sputum cytology, chest x-rays, or even CT scans, they just don't support wide-range population screening very effectively. CT scans are powerful, yes, but they have limitations in early sensitivity, and they're often prohibitively expensive for mass screening programs. Plus, you have concerns about radiation exposure.
Yeah.
They often lead to false positives, right? Which causes unnecessary anxiety and then more invasive procedures. Sputum cytology, biopsies. They are diagnostic, but they're invasive, sometimes painful, they carry risks. And even the advanced non-invasive techniques like mass spectrometry, which are incredibly precise in a lab. They're often bulky, they need highly specialized operators, and they're generally not portable or cost-effective enough for large-scale, accessible screening. So this leaves this huge diagnostic gap, particularly for early detection, which is exactly when treatment is most effective.
Okay, so it sounds like our current diagnostic toolkit, I mean, it's powerful in some ways, but it has some really profound limitations for widespread screening. So what kind of innovative solution could possibly address such a broad range of needs, something truly different that's, easy, affordable, doesn't involve needles or these massive, expensive machines? That's where the e-nose steps in, right? It almost sounds too good to be true, a simple breath test for such serious conditions.
You've precisely hit on the driving force behind all this research. The need is absolutely undeniable, and the e-nose offers a really promising pathway. To help guide us through this intricate and frankly rapidly evolving landscape, our roadmap for this deep dive is a comprehensive review article. It's titled Electronic Nose, a non-invasive technology for breath analysis of diabetes and lung cancer patients by Bahira and colleagues, published back in 2019. This paper meticulously details the state-of-the-art in detecting these volatile organic compounds, or VOCs as we call them. And it covers the sophisticated machine learning approaches being applied to these two really crucial clinical models, diabetes and lung cancer. It really showcases how far the technology has come and gives us a good sense of where it's headed.
Okay, let's unpack this amazing concept then. Our breath contains what exactly? Because when I think of breath, I naturally think oxygen in, carbon dioxide out, maybe a lingering hint of my morning coffee. But you're telling me there's a whole lot more going on in that seemingly simple exhale.
Oh, much, much more than just CO2 and coffee remnants. That's the core, fascinating insight here. Human exhaled breath isn't just air. It's this rich tapestry containing over 3,000 different volatile organic compounds, VOCs. And these aren't just random inert molecules floating around. They're complex gas mixtures. And they're either directly or indirectly linked to the incredibly intricate internal biochemical processes happening inside our bodies, moment to moment. You can think of them as tiny invisible chemical echoes, or maybe even miniature smoke signals, constantly being emitted from our internal workings. Now, to delve a bit deeper, when our organs or our metabolic systems are in a disease state, their normal biochemical processes inevitably change. And this leads to a crucial and detectable change, either the production of entirely new chemical compounds that weren't there before, or an altered rate of consumption or production of the existing ones. These abnormal changes directly impact the composition of our body fluids, like blood or urine. And critically, this altered chemistry is then reflected in the volatile organic compounds found in our breath.
So these unique breath signatures, or odor prints, they can serve as incredibly potent and non-invasive biomarkers for specific diseases, which offers immense potential not just for early detection, but also for ongoing analysis, monitoring disease progression or even how a patient's responding to treatment. It's almost like getting a daily report card for your health without any needles or invasive procedures. And this potential, it takes on even greater urgency when you look at the broader global health landscape. According to the World Health Organization, the WHO, non-communicable diseases NCDs, they're a devastating global burden. They account for a staggering 71% of global deaths every year. And within that tragic category, diabetes mellitus and lung cancer were ranked 6th and 7th respectively back in 2016 for the top 10 causes of death worldwide. So these are not minor health concerns. They represent a massive human cost and really underscore the critical urgency for improved, accessible, and user-friendly diagnostic tools like the eNose.
Okay, 3,000 VOCs. That is an absolutely immense number to sift through. So it's not just about the garlic, but a whole chemical symphony happening in there. How does an eNose even begin to make sense of that, let alone mimic our own incredible sense of smell, which is just such a marvel of evolutionary engineering?
It truly is a symphony, and you're right, our own biological sister is precisely where the inspiration comes from. The eNose technology is consciously engineered to mimic, or at least draw heavily from, the human olfactory system, which is this remarkably sophisticated integrated system combining our physical nose with our brain. It allows us to detect and distinguish this vast array of chemicals and, crucially, interpret complex scent patterns. Let's maybe draw a little analogy to understand it better. In the human nose, complex volatile compounds interact with specialized neuron cell receptors. Imagine them as tiny, highly specific locks. These interactions then generate electrical signals, nerve impulses, which are sent to the brain for initial preprocessing. Then in the final crucial step, these signals are stored and analyzed by specific brain regions, like the hypothalamus and the olfactory cortex. This allows us to identify and interpret smells as distinct perceptions. The eNose works in a remarkably similar way, though it's synthetic and electronic, of course. It combines several sophisticated components. First, a sensor array that's its artificial nose, designed to interact with VOCs. Then a data acquisition system that collects the electrical responses from these sensors, followed by a signal processing unit that cleans and organizes this raw data, a data storage facility to build up a library of scent profiles. And critically, artificial intelligence algorithms these act as its brain for the complex detection, analysis, and interpretation of chemicals in vapor form. If you can picture figure 1 from our source material, you can really see that direct parallel between the biological system and the electronic one. It's a true bio-inspired marvel.
This sounds like something straight out of science fiction, really. An electronic sniffer that could rival a dog's nose, or maybe even ours. But the concept isn't brand new, is it? This isn't just some recent invention.
No, you're absolutely right. The idea has been percolating for quite a while. The concept of the eNose emerged precisely because, while early chemical sensors were developed up until the 1980s, they simply couldn't mimic the mammalian nose effectively. The challenge wasn't just detecting a single gas. It was about recognizing patterns in complex mixtures, something our noses do almost effortlessly. The limitations back then were largely due to the electronics and the computational tools available. The processing power and AI capabilities just weren't there yet to handle such complex pattern recognition. But then came some really significant historical milestones that set the stage for what we see today. In 1982, the very first eNose was developed by Persaud and Dodd at Warwick University in the UK. This was a groundbreaking device. It used an array of multiple chemical sensors combined with a pattern recognition system, kind of rudimentary AI, to discriminate between different gases. This wasn't just a simple sensor detecting one chemical. It was a conscious effort to mimic that intricate multi-sensor detection and pattern interpretation of the human nose. That was a monumental leap. Then, similar work was extended by Ikegami and colleagues at Hitachi Research Laboratory in Japan in 1985. And the formal definition, the one we still largely use today, came in 1994. Gardner and Bartlett formally defined the eNose as an instrument which comprises an array of electronic chemical sensors with partial sensitivity and an appropriate pattern recognition system capable of recognizing simple or complex odors. That definition perfectly captures the dual nature, the physical sensors and the intelligent processing behind them. Over the last decade or so, research has really honed in on refining these core components. The emphasis has been on developing sensors that are not just sensitive, but highly selective, so they can pick out specific molecules from a crowd.
There's also been a big push to create more compact and energy-efficient electronic modules for amplifying, conditioning, and converting signals, which enables smaller, more portable devices. And crucially, we've seen immense advancements in the classifiers, primarily neural networks and other machine learning algorithms. These are vital for the learning and validation processes that allow the eNose to reliably identify distinct odor prints. This continuous refinement has made them increasingly powerful and precise.
That's a fascinating journey. And it's not just about health either, is it? These e-noses, they've found their way into all sorts of industries beyond just medical diagnostics, showing how versatile they really are.
Absolutely. The applications are incredibly broad, showcasing the versatility far beyond the clinic. Beyond biomedical and healthcare, you find eNoses deeply integrated into safety applications, ensuring air quality, detecting hazardous stuff like explosives or toxic gases in industrial settings, even environmental monitoring. They're vital in the food industry for quality control, assessing freshness, detecting spoilage in everything from milk to meat, ensuring product authenticity. The chemical and pharmaceutical industries use them for process monitoring, ensuring consistency and quality assurance during manufacturing, identifying contaminants. And just to give you a concrete sense of their real-world presence, some commercially available eNose systems include the Cerno 320, the Fox 4000, and the iPen. These are mentioned in Table 1 of our source. So these aren't just lab curiosities or future concepts. They are working tools already providing invaluable service across diverse sectors. So you see, the eNose is truly this sophisticated team of sensors and smart algorithms, each component playing a vital role. But having laid that scientific groundwork, let's maybe pull back the curtain on how they're actually built, piece by intricate piece. What about the noses themselves? These individual sensors that do the actual sniffing, what are they made of? And what makes them capable of detecting such tiny chemical signals in something as complex as breath?
Right. So if you were designing the perfect nose for an e-nose, a truly optimized chemical detector, what qualities would you be looking for? What's on the ultimate wish list?
That's an excellent and critical question, because achieving all these ideal qualities at the same time is still, frankly, the holy grail of sensor development. An ideal gas sensor for an e-nose would need a pretty challenging combination of features. It would need high sensitivity, meaning it could detect even tiny trace amounts of a chemical, maybe down to parts per billion. It would also need high specificity, so it could distinguish one chemical from potentially thousands of others in a complex mixture without getting confused. Excellent stability and reproducibility are absolutely paramount, ensuring consistent, reliable results over time and across different devices. That's vital for clinical use. A fast response and recovery time is also crucial, so you get quick readings without long delays between tests. Low sensitivity to humidity is a must, because our exhaled breath is naturally very humid, around 90% relative humidity, which can interfere with many sensors. It should ideally operate at a low temperature to save power and improve portability, and naturally be small in size and low cost for widespread adoption. Finally, it needs easy calibration and easily processable output data, so it can integrate smoothly with the AI brain. Now, achieving all of these perfectly in one single sensor is still a significant engineering and materials science challenge. But researchers have made incredible strides using various transduction principles, essentially, different ways of converting that chemical interaction into an electrical signal and a wide array of different materials. Each type of sensor has its own strengths and weaknesses, much like different specialized tools in a toolbox. Let's maybe dive into this spectrum of sensing materials, drawing heavily from Table 2 in our source material. First up, we have optical gas sensors. These work by measuring changes in optical properties, things like absorption, luminescence, scattering, or refractive index when they're exposed to gases. So some might change color or brightness in the presence of a specific chemical. Their main advantages are often excellent gas sensitivity and selectivity. They can be very precise. However, they come with significant disadvantages that make them less ideal for portable e-noses. They're difficult to miniaturize, often have a high cost, and require complex signal conditioning systems to interpret their optical output. So less suitable for that portable, low-cost point-of-care vision. Next are piezoelectric sensors. These include technologies like quartz crystal microbalance, or QCM, and surface acoustic wave, or SAW, devices. The principle here is quite elegant. These devices use a piezoelectric substrate that's a material that generates an electric charge when you apply mechanical stress, or vice versa. They measure gas-induced changes in the resonant frequency of a traveling wave on this substrate. When VOC is absorbed onto a specialized coating on the sensor surface, it changes the mass slightly, which in turn alters the frequency of the wave. Very sensitive. Their advantages are quite compelling. High sensitivity, small size, fast response time, low power consumption, robustness. They also have good CMOS compatibility, meaning they can be easily integrated with existing microelectronic circuits, which helps hugely with miniaturization and cost. And they have excellent scalability for mass production. However, they can struggle with a relatively poor signal-to-noise ratio, especially due to their high operating frequencies. And they often require complex electronic circuits for precise signal delineation. They can also show instability at higher temperatures, which limits their operating range sometimes. Then we encounter polymer-based sensors. These utilize polymer composites that have reversible physicochemical properties. Essentially, the weak, temporary physical absorption of VOCs onto a polymer surface, often due to dipole interactions, changes its properties. It might change its electrical conductivity if it's a conducting polymer, or its mass if it's a non-conducting polymer used as a coating in piezoelectric sensors. These sensors boast several attractive features: high sensitivity, selectivity, and the crucial ability to operate at room temperature, which saves a lot of power. They also offer low fabrication cost, a truly portable structure, and low power consumption. But they do face issues sometimes with response and recovery time, durability, instability, maybe irreversibility over many cycles, and sometimes poor selectivity if the polymer interacts with too many different VOCs. This brings us to the metal oxide semiconductor, MOS sensors, often considered the real workhorses, kind of the backbone of many ENOS designs. These are solid-state resistive sensors using metal oxides like tin oxide, SnO2, zinc oxide, ZnO, copper oxide, CuO, titanium dioxide, TiO2, tungsten oxide, WO3, nickel oxide, NiO. They exhibit a measurable change in their electrical resistance when they interact with specific gaseous analytes. Their advantages are numerous and significant for ENOS development. Simplicity in design, high sensitivity, low cost, good stability, and excellent compatibility with modern electronic devices. Now, diving a bit deeper into these SMOs, or semiconducting metal oxides, many of them traditionally operate at relatively high temperatures, usually between 100 and 500 degrees Celsius. This elevated temperature is often needed to activate the surface reactions between the metal oxide and the gas molecules. It requires microheaters to maintain that optimal temperature. However, microelectromechanical system, or MEMS-based technologies, are really revolutionizing this. They allow fabrication of these sensors on tiny diaphragms, which dramatically reduces the power consumption needed to heat them. Figure 2 in our source visually represents this with ZnO and CuO nanoflakes on MEMS structures. Furthermore, nanosynthesis creating nanostructures of these metal oxides, like nanowires, nanobelts, or nanoparticles, really enhances their performance. That's because these nanostructures offer a much higher surface-to-volume ratio, providing far more active sites for interactions with VOCs, leading to much greater sensitivity.
Okay, so these MOS sensors sound really promising, kind of the go-to option in many cases.
They often are, but one key challenge with individual MOS sensors is typically their inherent poor selectivity. They might react, to some degree, to several different gases. However, this is precisely where the array part of the ENOS comes in. By using multiple MOS sensors in an array, each maybe with slightly different sensitivities or coatings, combined with those advanced machine learning algorithms we talked about, the system can piece together a unique fingerprint for a specific gas mixture. This approach significantly improves the overall selectivity of the entire ENOS system. It's like having a choir of slightly imperfect singers that, together, create a perfect identifiable harmony. And finally, we have field effect transistor, FET, gas sensors. The principle here is that the interaction between chemical molecules and the source drain channel of the transistor modifies its fundamental electrical behavior. This leads to detectable shifts in current, or threshold voltage, or carrier mobility. These are often nanomaterial-based, utilizing cutting-edge materials like carbon nanotubes, graphene, or metal oxide nanowires.
These FET sensors certainly sound incredibly promising, almost like a glimpse into the ideal future sensor, offering amazing precision. But what are the current roadblocks? Why aren't they everywhere yet?
Yeah, they definitely hold incredible potential. FET sensors are ultra-sensitive. They possess great absorptive capacity thanks to their nanomaterials. They can be highly miniaturized. They offer excellent stability. And they have high compatibility with standard integrated circuit, or IC, fabrication technology. That means they can potentially be built using existing microchip manufacturing processes, which is huge. However, their current drawbacks include significant difficulties in fabrication, ensuring repeatability, making sure each sensor behaves exactly the same at a relatively high cost, partly due to the complex nanomaterial integration. But the promise they hold for future generations of ENOSes is absolutely undeniable. What this vast array of sensor types really reveals is that the ENOS isn't a single fixed device, but a highly adaptable platform. It's really a testament to how researchers are custom engineering the perfect sniffer for incredibly specific and challenging tasks. Each material offers a unique advantage in the quest for precision. The key insight here isn't about finding a single best sensor, but the power of a diverse toolkit tailored to the mission, combined with smart interpretation. Now, it's also important to briefly acknowledge that there are other powerful, high-sensitivity analytical techniques for detecting VOCs out there, often considered the gold standards in analytical labs. These include gas chromatography, GC, gas chromatography, mass spectroscopy, GCMS, proton transfer reaction mass spectrometry, PTRMSS, and ion mobility spectrometry, IMS. And these methods can indeed detect trace amounts of VOCs with exquisite precision. They've been successfully applied in various industries. However, their fundamental limitation for our purpose, for the Eno's vision, is their bulkiness, their high cost, and the fact they usually require highly trained personnel to operate them. This makes them generally unsuitable for the portable, low-cost, and user-friendly Eno system that's the focus of this deep dive. They are fantastic laboratory instruments, absolutely, but just not practical for widespread point-of-care screening in a doctor's office or maybe even a home setting.
So we've explored these amazing sensors, the noses of the Enos, built from incredible materials using intricate principles. They gather this huge amount of complex data, but how do we interpret all that raw input? That's where the brain comes in, right? It's like going from individual sensory inputs to a complete actionable understanding, like recognizing a distinct aroma from lots of faint smells.
Precisely. Imagine you have an array of sensors, maybe dozens, each one giving a slightly different electrical wiggle, a unique signal in response to a breath sample. Almost like different instruments in an orchestra playing slightly different notes. How do you turn that cacophony, that complex pattern of individual signals, into a clear, actionable diagnosis? Well, in an Eno system, the electrical signal patterns from the sensor array are first put through a series of crucial pre-processing steps, things like weighting, standardizing, and normalizing the data. This meticulously cleans, organizes, and scales the raw data, essentially making it suitable for the subsequent statistical analysis. The ultimate goal here is then to convert that analyzed data from usually higher dimensions down to lower dimensions. Think of it like taking a very high-resolution photo with millions of pixels and then intelligently compressing it into a smaller, more manageable file size that still retains all the essential visual information. This process essentially distills the data, reducing noise and redundancy, allowing us to focus on the chemicals of interest and extract the most meaningful patterns. Now, the process of pattern analysis, which is where the AI, the machine learning, really flexes its muscles, generally falls into three main categories. The first is graphical analysis. This is the simplest form. It involves visually interpreting chemical signatures using tools like bar charts or maybe polar plots, comparing the sensor responses against a known reference profile. It's useful for quick, intuitive visual interpretations when the data isn't overwhelmingly complex. But it quickly becomes impractical and pretty much uninterpretable when you're dealing with the high-dimensional data that's typical of a breath sample containing potentially thousands of VOCs. The second approach is multivariate data analysis. The core purpose of these techniques is to reduce the dimension of that complex response data, often by mathematically eliminating or minimizing the impact of disturbing variables, like ambient temperature and humidity, which can really confound the results if you don't account for them. A key technique routinely used in Eno systems for this dimensionality reduction is principal component analysis, or PCA. What's particularly interesting about PCA is that it's an unsupervised learning technique. This means it can identify underlying patterns and differentiate chemicals without prior knowledge or pre-labeled training data. It doesn't need to be told what's what beforehand. It essentially finds the directions, the principal components, in the data where there's the most variance. This allows us to see clusters and relationships that might be completely hidden in the raw, high-dimensional data. It's like finding the core themes in a complex symphony. The third category, and arguably the most critical for practical application, is neural network analysis and classification. Because the prime purpose of an Enos, after all, is to identify chemicals qualitatively, what chemicals are present, and quantitatively how much of them there is. This requires robust classification techniques that can actually learn from data. Key techniques here include support vector machines, or SVM, which are excellent at finding optimal boundaries to separate different data groups with the maximum possible margin, making them really powerful for classification tasks. Then there's K-nearest neighbor, or KNN, which classifies new data points based on the characteristics of their closest known neighbors in the dataset. It's quite intuitive. And of course, artificial neural networks, or ANN, which are inspired by the brain's learning processes to recognize complex patterns and make predictions. These advanced algorithms identify chemicals based on mathematically trained models. They learn to recognize specific odor prints associated with different conditions, much like a skilled perfumer can identify individual notes in a complex fragrance after enough experience.
So the AI is kind of the interpreter, translating the raw sensor language into something meaningful, like a diagnosis.
Exactly. And what's truly crucial here is that when results from both neural network analysis like ANNs or SVMs and multivariate analysis like PCA show good agreement, it significantly boosts the conformational accuracy and the overall reliability of the chemical identification. That's why machine learning ML isn't just some add-on feature. It's absolutely integral to modern e-nose systems. It acts as the intelligent brain that translates the nose's raw sensory data into meaningful, potentially diagnostic insights. Now, delving deeper into the art, or maybe the science, of machine learning in e-noses, it's far from a one-size-fits-all solution. It's a really active area of research and refinement. Researchers use a diverse array of methods for everything, from optimal sensor selection, choosing the right combination of sniffers for the job, to meticulous data acquisition and pre-processing methods, effective dimensionality reduction techniques like PCA or others, the nuanced choice of classifier SVM versus KNN versus ANN, for example, and rigorous validation of the models to make sure they generalize well. This constant experimentation with different combinations is what continuously pushes the field forward, improving accuracy and robustness. Let's look at some specific examples from the research to make this more concrete. Et al. In 2017, for instance, used different sensor arrays combining electrochemical, catalytic combustion, hot wire, and MOS sensors. And they tested 5 different machine learning methods. They look at things like linear discriminant analysis, or LDA, which is a classification technique that projects high-dimensional data onto a lower-dimensional space while maximizing the separation between classes. They concluded that LDA combined with fuzzy KNN and LDA combined with SDM offered the optimal classification performance in their study, achieving an impressive 91.59% accuracy for lung cancer screening. Another significant study by Haryanto et al. In 2017 compared KNN, SVM, and ANN specifically for diabetes detection. They found that KNN, particularly when used with data normalization, was optimal in their setup, achieving a remarkable 95.0% accuracy. But a crucial point, and one that highlights the complexity in real-world application, is that while ML often provides excellent differentiation between broadly diseased and non-diseased states, it doesn't always properly differentiate various specific disease states from each other. Or perhaps more importantly, it doesn't always adequately account for those pervasive confounding factors we discussed earlier, things like age, sex, smoking status, or even the exact sampling site or technique used. These factors can introduce noise that isn't related to the disease itself, but can easily confuse the algorithm if not handled carefully. Nakle et al. In 2017 directly addressed this challenge. They used hierarchical clustering to check resemblances across these confounding factors. They found an average accuracy of 86% across 120 different discriminant function analysis models when classifying 17 different diseases, showing that careful handling and accounting for such variables is absolutely vital for reliable multi-disease classification. Other researchers have focused on improving specific components of the ML pipeline. Yan et al. In 2014, for example, showed that sequential forward selection, or SFS, which is a method for selecting the most informative subset of features, sensor responses in this case, from a larger set to build a model, provided better results in standard PCA for dimensionality reduction in certain contexts related to diabetes detection. They also introduced a clever model fusion approach, combining subject-specific training data with general training data, which effectively reduced the risks of overfitting the model. Overfitting is a common pitfall where a model performs brilliantly on the data it was trained on, but poorly on new, unseen data, which makes it useless clinically. And Blatt et al. Back in 2007 found that a non-parametric approach, non-parametric linear discriminant analysis, or NPLDA, was actually superior to PCA for feature extraction specifically in lung cancer identification in their study. This suggests that the best algorithm often depends heavily on the specific disease, the sensors used, and the characteristics of the dataset itself. So this constant evolution and the varied findings across different studies reinforce a key takeaway. There's likely no single combination of pattern recognition algorithms that is superior to all others. It really requires applying and meticulously optimizing various combinations of dimensionality reduction and classification techniques to achieve the best possible classification accuracy for any given disease or application. This means continuous research, adaptation, and fine-tuning are absolutely essential for each new e-nose application. Now, despite these incredible advancements and the really compelling results we see in research settings, it's important to acknowledge that these techniques haven't been fully adopted into widespread clinical practice yet. there are still significant hurdles related to standardization across devices and labs, navigating complex regulatory approval processes, and conducting large-scale validation studies across diverse patient populations. But with the increasing pace of research, continued refinement of both hardware and software, and hopefully improved regulatory pathways, Eno's diagnostic tools absolutely have the potential to match and maybe even supersede classical diagnostic methods in the future. They could fundamentally transform how we approach early diagnosis.
Okay, so the eNose has the sensors to sniff and the AI to think, learning to distinguish between healthy and diseased states. But let's get back to the actual language of the breath itself for a moment. We've talked about these thousands of VOCs. But what exactly are these tiny compounds it's sniffing out? And what makes them specifically telltale signs of disease? It feels like we're trying to read a very complex chemical dictionary here.
It truly is a vast and incredibly nuanced chemical library. Yes. And every compound, or even just its concentration relative to others, can carry a vital piece of information. Over 3,000 VOCs have indeed been detected in exhaled breath, as we mentioned, and they vary both qualitatively, meaning which specific compounds are present, and quantitatively, meaning how much of each is present from person to person, and even within the same person over time. Fundamentally, these compounds originate from metabolic alterations or malfunctions happening inside our bodies. When something is amiss, whether it's inflammation, infection, or a disease like cancer or diabetes, our internal chemistry subtly shifts, and these shifts are directly reflected in our breath's unique chemical composition. We generally categorize these VOCs primarily into two main groups: endogenous and exogenous. Endogenous VOCs are the ones that originate directly from our internal metabolic processes. These are the most clinically valuable for diagnosis because they directly reflect internal changes due to specific physiological or pathological conditions. They are the true internal messengers of our health state, offering direct insights into things like cellular activity, inflammation levels, or active disease progression. Exogenous VOCs, on the other hand, come from current or previous environmental exposure. This could be anything from the food we just ate, to medications we're taking, pollutants in the air we breathe, cosmetics we use, or even historical factors like smoking habits. Now, while they can sometimes complicate testing by introducing noise or background interference during measurements, they can also hold significant historical information about a patient's lifestyle, habits, and environmental interactions. Interestingly, these exogenous VOCs have been less studied specifically for disease diagnostics, but they certainly hold untapped potential for broader health profiling and perhaps even personalized medicine approaches in the future. A significant challenge, however, is that finding the exact and consistent concentration of these exhaled VOCs for precise medical interpretation is actually quite difficult. There's immense variability. Typical endogenous VOC concentrations in breath can range anywhere from 1 part per billion, or ppb, which is incredibly tiny, up to maybe 5,000 ppb. And crucially, these concentrations are strongly dependent on numerous factors beyond just the disease state itself. We're talking about lifestyle choices like exercise, the specifics of our diet, high fat versus high carb, our age, gender, weight, smoking habits, the presence of other comorbid diseases, and even the medications we use. For instance, your gut microbiome, which is heavily influenced by your diet, actually produces a large number of VOCs that end up in your breath. This inherent and broad variability is a major hurdle that Eno's development must continuously address, mainly through sophisticated sampling protocols and robust machine learning algorithms to ensure consistent accuracy and reliability in diverse real-world clinical settings.
What kinds of chemicals are we primarily talking about when we say volatile organic compounds? Are there common chemical families that show up, and do they tell us different things about what's happening inside?
Yes, definitely. There are distinct chemical categories that most of these endogenous VOCs fall into, and each category can provide unique clues about different metabolic pathways or cellular processes. These include things like saturated hydrocarbons, unsaturated hydrocarbons, various oxygen-containing species such as alcohols, aldehydes, acids, esters, and ketones, as well as nitrogen-containing compounds and sulfur-containing compounds. It's a pretty broad chemical spectrum. And the presence or absence, or perhaps more often, the altered ratios between these different groups can signal underlying physiological changes. To give you a sense of their origin stories, hydrocarbons, for example, are often produced by processes like lipid peroxidation that's damage to fats and cell membranes, or protein oxidation or DNA damage. These damaging cellular processes are frequently caused by inflammatory cells and reactive oxygen species, or ROS, those unstable molecules that can cause cellular damage when they're out of balance. So an increase in certain hydrocarbons might indicate higher levels of oxidative stress or inflammation somewhere in the body. Other groups of VOCs, like alcohols and ketones, evolve via different biochemical and physiological processes. For instance, as we'll discuss with diabetes, ketones are a key byproduct of fat metabolism when glucose isn't available. The key insight is that abnormal levels or altered ratios of these VOCs don't just happen randomly. They specifically indicate a different metabolic status within the body. And that difference is precisely what allows us, or rather the eNOS and its algorithms, to potentially differentiate between healthy and diseased individuals. What's more, monitoring these VOCs over time could even show the progress of a patient's treatment, acting as a real-time, non-invasive indicator of how their body is responding therapeutically.
Okay, so if everything from my diet, my environment, my activity level influences these VOCs, how do we make sure we're getting a true untainted breath print? One that genuinely reflects health status and not just, the pizza I had last night or the fumes from traffic on my way here. The integrity of the sample seems absolutely vital for getting an accurate diagnosis.
You've hit on one of the most critical practical challenges for eNOS implementation and eventual clinical translation, breath sampling. It sounds simple, but it's really not. Contamination by background VOCs from the ambient environment, or even improper methodology during the breath collection itself, can easily lead to false positive or misleading results. It can essentially obscure the true disease signature we're trying to detect. This is a fundamental factor that needs meticulous control and standardization. To try and obviate these issues and ensure the best, most reliable results, following recommended guidelines is absolutely crucial. For example, the European Respiratory Society, or ERS, has published a very comprehensive technical standard document specifically on breath sampling that outlines best practices. Factors like whether you inhale filtered or unfiltered ambient air before exhaling can profoundly influence the VOC pattern. Unfiltered air might contain environmental contaminants that end up in the sample. Similarly, whether it's a single forceful exhalation or multiple, more gentle ones matters. And whether the collected breath is mixed expiratory air, just everything you breathe out, or specifically end-tidal air. That's the very last portion of an exhaled breath, which is thought to be most representative of the air in the alveoli, down in the lungs where gas exchange actually happens. All these details significantly influence the resulting VOC pattern. Researchers like Bikoff et al. And Boshier et al. Have even rigorously studied the influence of things like the expiratory flow rate, how long you hold your breath before exhaling, and the impact of the anatomic dead space, the upper airways, where no gas exchange occurs on VOC patterns. It demonstrates just how many variables can shift that delicate odor print. Ensuring a standardized and clean sample is almost as complex and important as the sensor analysis itself.
Wow. That truly highlights how much precision and careful methodology are needed, even for what sounds like a simple breath test. It's definitely not just about blowing into a tube. It's a complex science in itself, just to ensure you get a clean, reliable sample that can accurately inform a diagnosis.
Indeed. The key insight here is that human breath is an incredibly rich but equally complex biological matrix. Its thousands of VOCs are undoubtedly a treasure trove of potential information, but extracting that information accurately demands a deep understanding of both human physiology and the implementation of rigorous sampling protocols. This allows us to confidently differentiate between the true endogenous biomarkers we're interested in and all the extraneous noise from the environment or lifestyle factors.
Okay, now that we understand the VOCs themselves, these chemical messengers, and the rigorous methods needed to collect them cleanly, let's pull back and look at how the eNOS is actually being deployed, maybe not in every clinic yet, but in advanced research to tackle specific diseases. Starting with diabetes. Diabetes affects literally hundreds of millions of people globally. It comes with this devastating array of serious complications: kidney failure, heart disease, blindness, even limb amputations. How has the eNOS offered a glimpse into better, maybe more accessible, non-invasive detection for this silent, widespread epidemic?
Right. Diabetes is fundamentally a metabolic disorder characterized by persistently high blood glucose levels. Just to quickly recap the main types. There's type 1 diabetes, which is an autoimmune condition. The body's immune system mistakenly attacks and destroys the insulin-producing beta cells in the pancreas, leading to insufficient insulin. Then there's type 2 diabetes, much more common, where the body either doesn't produce enough insulin or more often doesn't use the insulin it produces, effectively a condition known as insulin resistance. And gestational diabetes mellitus, or GDM, which develops during pregnancy and can affect both the mother and the child. Plus, there are other less common forms, like monogenic diabetes and drug-induced diabetes. The eNOS really aims to address a huge unmet need across all these types for a more patient-friendly, accessible, and less burdensome screening and monitoring method. The goal is to catch the disease earlier and help manage it more effectively day to day.
Now, the source material mentions a distinctive sweet smell associated with diabetic patients, something apparently observed anecdotally for a long time. What's the actual science behind that observation? Is it just folklore, or is there a real chemical basis?
No, it's not just folklore. That sweet smell was indeed observed historically by clinicians, long before we fully understood the underlying biochemistry. It was later scientifically identified that diabetic patients, particularly those with poorly controlled diabetes or those experiencing a dangerous condition called diabetic ketoacidosis, often have significantly elevated concentrations of specific ketone bodies in their blood and consequently in their breath. These primarily include acetone, along with beta-hydroxybutyrate and acetoacetate. To understand the biochemical pathway involved, in diabetic patients, because of either insufficient insulin or ineffective glucose metabolism, the body struggles to use glucose for energy. So, as an alternative fuel source, it starts aggressively metabolizing fatty acids. This process of breaking down fatty acids leads to the production of these ketone bodies. Specifically, acetoacetate is a key intermediate derived from lipid peroxidation. It generates beta-hydroxybutyrate, which can be used as an energy source by some tissues. But the non-enzymatic decarboxylation, basically a chemical reaction without an enzyme of acetoacetate, forms acetone. Now, acetone is highly volatile, meaning it easily turns into a gas. Once formed, it gets absorbed into the bloodstream and is subsequently transported to the lungs, where it's exhaled with the breath. Figure 3 in our source material visually explains this acetone formation process, starting from fatty acids, really illustrating how that metabolic shift directly translates into a detectable breath signature. This makes breath acetone a very promising biomarker for diabetes. The typical breath acetone concentration in diabetic patients is often observed to be over 1.7 parts per million, or ppm. That's generally at least 2 times higher than the levels found in healthy individuals. And research by Wang et al. Back in 2010 even reported finding a linear dependence between breath acetone concentration and blood glucose levels, suggesting a direct measurable correlation that could potentially be exploited for both diagnostic and monitoring purposes. However, and this is a crucial caveat, it's not a perfectly straightforward one-to-one relationship, and this presents a key challenge for eNOS applications. Some authors have actually contradicted a simple, clear link, because acetone generation is heavily influenced by all those confounding factors we discussed earlier. Things like age, gender, the precise timing and nutritional content of meals, fasting versus post-meal, the amount of food consumed, physical activity levels, smoking status, even whether the collected sample is mostly alveolar air from deep in the lungs or mixed expired air, and the presence of other disease conditions. For example, vigorous exercise or prolonged fasting, even in healthy individuals, can temporarily elevate acetone levels as the body starts burning fat. This inherent variability is a really critical challenge that eNOS systems must overcome, likely through sophisticated algorithms that can factor out these variables to ensure consistent accuracy and reliability in real-world clinical settings.
Okay, so given those complexities and the existing variability, why is measuring breath acetone with an eNOS potentially so much better or more advantageous than, say, using urine or blood tests for ketones? Those methods are already established in clinical practice. What are the eNOS's unique advantages here?
That's a vital question, absolutely. A breath VOC-based screening method offers some significant advantages and avoids several inherent shortcomings of both urine and blood-based methods for ketone detection. Let's take urine tests. While they are non-invasive, they are generally considered less sensitive to early markers like beta-hydroxybutyrate. Beta-hydroxybutyrate often appears earlier in the metabolic changes of developing ketoacidosis than acetone does. Urine tests also typically only provide an average ketone concentration accumulated since the last time the bladder was emptied, unless you use a catheter, which obviously introduces invasiveness. Moreover, they can be unreliable or difficult for certain patient groups, think patients with renal failure or other kidney conditions, or those who have difficulty passing urine, like infants or some elderly patients. Now, blood tests for ketones, they offer more immediate and precise readings of current levels, but they are inherently invasive, requiring repeated finger pricks or even venipuncture, drawing blood from a vein. They also necessitate trained staff for collection and analysis, optimum sterilization procedures to avoid infection. And they can be painful or anxiety-inducing for many patients, especially children who might need frequent monitoring. Furthermore, the VOC concentration measured in blood can sometimes actually be affected by other blood components, like high levels of vitamin C, potentially leading to interference in some measurement techniques. So the breath method offers a truly non-invasive, potentially continuous, and far more patient-friendly alternative. It removes many of these practical and psychological barriers to regular screening and effective monitoring.
So how have researchers and engineers been tailoring and advancing these e-noses to overcome those specific challenges, the humidity, the other interfering VOCs, and specifically detect diabetes reliably?
Right, the main hurdle for the eNOS and diabetes detection has really been the accurate and selective quantification of breath acetone. This is largely due to interference from that high water vapor content, remember. Exhaled breath is around 90% humidity, which can easily swamp many sensors or alter their response. And also interference from other VOCs like ethanol, ethylbenzene, methyl nitrate, and xylene, which might be present in breath and can have similar chemical properties to acetone, potentially causing false readings. Now, while highly accurate but also expensive and bulky, lab techniques like GCMS, SIFT-MS, selected ion flow tube mass spectrometry, and PTRMS are currently used as the gold standards for research. The eNOS aims to provide a solution that is portable, enables real-time monitoring, is accurate, much smaller in size, and crucially, low cost enough for widespread adoption. There's been some truly pioneering work in this specific area over the years. Liu et al., back in 2006, for example, used an array of 32 sensors decorated with single-walled carbon nanotubes, CNTs, along with metal nanoparticles and polymers. They processed the complex sensor responses using PCA to successfully detect acetone, demonstrating early promise for diabetes applications. An even earlier eNOS tool, developed by Mohammed et al. In 2002, achieved an impressive 96% classification accuracy for type 2 diabetes. Interestingly, they did this by analyzing the smell of urine samples from patients, using an 8-sensor array and PCA, an interesting early pivot from direct breath analysis. And Ping et al., way back in 1997, developed an eNOS using metal-catalyzed SNO2 sensor arrays that successfully diagnosed diabetes in 32 volunteers using breath samples. That provided a very early, crucial proof of concept for direct breath analysis for diabetes. More recent advancements have really focused on refining both the sensors and the algorithms. Yan et al. In 2012 utilized 9 commercial sensors, importantly including dedicated temperature and humidity sensors, actively account for those environmental factors. They used this setup to discriminate diabetes with a high 91.43% sensitivity and 89.86% specificity. Guo et al. In 2010, employed 12 commercial TGS, or Taguchi gas sensors. These are robust metal oxide semiconductor sensors combined with a machine learning system. They achieved 87.67% sensitivity and 86.87% specificity for diabetes diagnosis. Importantly, this study also achieved a pioneering 68.66% accuracy for actually monitoring blood glucose levels, which was a significant step forward for portable eNOS, moving beyond just binary diagnosis towards continuous management potential. Yan et al., again in 2014, developed an even more highly accurate system reporting over 90% accuracy for both diabetes screening and blood glucose monitoring. They achieved this by using a subject-specific prediction model with PCA, demonstrating the power of personalized algorithms tailored to individual variations. However, it's definitely not without its ongoing limitations, and the path to routine clinical integration is still being paved. Leopold et al. In 2017, for example, specifically studied glucose monitoring in critically ill intensive care unit ICU patients, a very challenging population. They used metal oxide sensors, PCA, and linear regression. Their conclusion was that while the eNOS showed promise, it alone couldn't predict exact blood glucose levels in these specific intubated ventilated ICU patients with the high precision needed for critical care decisions in that setting. This really highlights that there are still complex physiological factors and the extreme variability found in critically ill patients that need to be better understood and accounted for. It emphasizes the continuous need for refinement and robust validation across diverse patient populations and clinical contexts.
It sounds like beyond these general arrays trying to capture patterns, individual sensors are also getting incredibly smarter, especially with the whole revolution in nanotechnology, right? This seems to hint at true miniaturization and maybe enhanced specificity, really zeroing in on target molecules like acetone.
Absolutely. That's a key and very exciting direction for advanced eNOS development. To reduce the need for incredibly complex signal processing or broad pattern recognition across large arrays, researchers are increasingly focusing on developing individual nanosensors. These often incorporate specialized sensing materials, specifically engineered at the nanoscale, to detect sub-ppm concentrations of acetone with very high selectivity, even within the complex mixture of breath. There's a lot of exciting material innovation happening at this nanoscale level. For example, various SMOs, those semiconducting metal oxides, are being heavily explored and engineered. Researchers are working with advanced materials like indium-loaded WO3 SNO2 nanocomposites, platinum functionalized WO3 hemitubes, chromium-doped AWO3 nanoparticles, rhodium oxide functionalized WO3 nanofibers, and even carbon-doped WO3. Each of these engineered nanomaterials exhibits excellent acetone sensing characteristics, often by having specific surface chemistries or unique crystal structures that preferentially interact with or bind to acetone molecules, boosting selectivity. Now, a major hurdle, as we've touched on, is that extremely high relative humidity, around 90% RH, in exhaled breath. It heavily interferes with many sensor measurements, often by occupying the sensor binding sites meant for acetone or by altering the sensor's electrical properties. But researchers are making impressive strides in overcoming this significant challenge. Kim et al., in 2016, for instance, demonstrated that their RH203 functionalized WO3 nanofibers were capable of detecting 1 ppm acetone in a remarkably high 95% RH environment. This is highly significant because it means the sensor can maintain its performance even in the very humid, realistic conditions of human breath, a crucial step towards achieving clinical viability. And here's where it gets really interesting, specifically for diabetes detection. The work by Rigatoni et al. In 2010 and 2012 achieved truly significant success using psi-doped WO3, that's silicon-doped tungsten oxide prepared by a technique called spray pyrolysis. They meticulously optimized the silicon doping concentration, finding that using 10 mol% psi-doped WO3 was optimal. This specific formulation achieved excellent acetone sensing performance in both dry and high RH environments. Figure 4 in our source material beautifully illustrates this, showing the sensor's highly selective and sensitive response characteristics with respect to varying psi-doping levels and under different humidity conditions. Their optimized sensor successfully differentiated diabetic subjects from healthy controls based on breath acetone. And importantly, their real-time breath acetone measurements showed an impressive 98% accuracy when verified against a PTRMS detector, which is considered a gold standard analytical instrument. Crucially, their sensor even responded reasonably well to different expiratory flow rates, mimicking the diverse breathing conditions found in real-world patients. That's a major step towards demonstrating practical applicability beyond controlled lab settings. However, there are still production challenges to address for widespread use. Spray pyrolysis, while effective for research-scale synthesis, can sometimes have issues with achieving uniform coatings over large areas, which is needed for mass production. Also, while these high-performance sensors are incredibly impressive, they still often require relatively high operating temperatures, perhaps around 400 degrees C, to achieve peak performance. This can consume more power and pose challenges for true miniaturization into low-cost, battery-powered portable devices. To address some of these manufacturing difficulties, Ridos et al. In 2016 explored sputtering as potentially a simpler, more scalable deposition technique compared to spray pyrolysis, seeking more cost-effective production methods. And other nanomaterials are also showing great promise. Things like platinum-decorated porous SNO2 fibers and SNO2 CNT nanocomposites, explored by Shin et al. And Narjaneri et al., have also achieved impressive ppb-level acetone detection even in high humidity. Plus, emerging materials like graphene, graphene oxide, and reduced graphene oxide combined with SMOs, investigated by Choi et al. And others, are attracting considerable interest due to their unique electronic properties and potential for ultrasensitive detection. So despite these incredible advancements in sensitivity, selectivity, response time, and even lower power consumption at the sensor level, significant work is still needed, particularly for large-scale, cost-effective production of these next-generation nanosensors and their seamless automatization for widespread diabetes screening programs. Additionally, there's an ongoing need to develop even more robust and accurate machine learning algorithms that can reliably predict not just the presence of diabetes, but perhaps even breath acetone intensity, and ultimately correlate that accurately with real-time blood glucose levels. That's the ultimate goal for management.
Just imagine a world where daily glucose monitoring is as simple and as painless as just breathing into a small handheld device. No more finger pricks, no more blood draws. It really makes you think about the daily burden on patients, especially children with type 1 diabetes. The potential here for improving quality of life, reducing pain and anxiety, and vastly expanding accessibility to monitoring is truly immense. It could offer a new sense of freedom and control for millions of people managing diabetes every single day. Okay, so from that sweet breath signaling diabetes, let's shift focus now to a potentially more sinister scent signature. Let's explore how the e-nose is being deployed in the incredibly critical fight against lung cancer, another devastating disease where early detection is just absolutely vital for survival.
Lung cancer is indeed a deadly foe. It's a silent killer that often goes undetected until it reaches advanced stages, when treatment options become much more limited and less effective. It consistently ranks as one of the leading causes of cancer death globally year after year. And the stark reality is that the survival rate for stage I lung cancer, when the tumor is small and hasn't spread, is significantly better than for later stages, sometimes dramatically so. This profound difference in prognosis makes early diagnosis not just desirable, but absolutely critical for improving survival rates and offering patients more effective, potentially curative treatment options. The limitations of our current diagnostics for lung cancer are profound, particularly when you think about implementing mass population screening programs. Conventional methods like CT scans, while powerful for detecting established tumors, have relatively weak sensitivity for very early-stage disease or precancerous lesions. And as we mentioned, they're prohibitively expensive for mass screening. Plus, you have the concerns about cumulative radiation exposure from repeated scans and the significant issue of false positives, which lead to patient anxiety and often necessitate further invasive procedures like biopsies, which carry their own risks. More invasive procedures like bronchoscopy inserting a scope into the airways definitely carry risks of complications, require anesthesia, and can cause significant patient trauma and discomfort. Other methods like sputum cytology, examining cells from coughed-up mucus, needle biopsies, and even advanced PCR sputum assays all have their own inherent limitations regarding cost, invasiveness, sensitivity, and scalability for wide-range screening programs. They're often only used after a suspicious mass has already been detected, not for initial screening. These inherent limitations really highlight the urgent, pressing need for a non-invasive point of care and user-friendly diagnostic technique like the eNose. It could offer immense value by catching the disease much earlier when it's most treatable.
So, just like diabetes seems to have its specific breath signature with acetone and ketones, does lung cancer also have its own unique odor print that an eNose can learn to detect? What kind of chemical clues are we talking about in this case?
Yes, absolutely. The concept that specific VOCs are associated with lung cancer isn't new. Researchers like Gordon et al. Identified some of them as far back as 1985. Since then, thanks to more advanced analytical techniques like GCMS, a much more comprehensive list of key VOCs has been identified. These are compounds found to be consistently elevated or present in different ratios in the breath of lung cancer patients compared to healthy control subjects. The list includes a really broad spectrum of chemicals, things like benzene, toluene, styrene, various alkanes like decane and isobutane, alcohols like methanol and ethanol, ketones like acetone again, pentane, isoprene, isopropanol, dimethyl sulfide. Also specific compounds like 2-methyldedicane, 2-tridecanone, 2-pentadecano, echicosane, SEC2-decano, 2-hendecanone, 2-methylnaphthalene, nonedicane, icosane carbon disulfide. And various aldehydes like butanol, formaldehyde, acetaldehyde, pentyl, hexanol, and octanol, just to name quite a few. It's a very complex and distinct chemical signature, almost like a unique constellation of molecules specific to the presence of lung cancer. What's really fascinating here is not just that these changes occur, but trying to understand why they occur. What's happening biologically? We now have a hypothetical pathophysiological model, which is visually represented in Figure 5 from our source material, that helps explain this altered breath signature. So in healthy cells, reactive oxygen species, or ROS, are produced at a definite controlled rate as part of normal cellular activities like respiration. These ROS contribute to the normal background production of certain volatile alkanes, which are then exhaled as part of the healthy VOC profile. However, in cancer, those rapidly proliferating cells often thrive in hypoxic conditions, meaning low oxygen environments within the tumor mass. They also exhibit impaired mitochondrial respiration and shift towards a much higher rate of glycolysis, even when oxygen is present. This metabolic reprogramming is famously known as the Warburg effect, and it creates a unique, often acidic microenvironment within and around the tumor. Simultaneously, genetic mutations common in cancer, such as the increased expression of certain cytochrome P450 enzymes, which are notably associated with smoking and lung cancer risk, as these enzymes are involved in metabolizing carcinogens found in tobacco smoke, can accelerate the breakdown, or catabolism, of oxidative stress products. So all these interconnected changes, the altered metabolism, Warburg effect, increased oxidative stress from ROS, and specific enzyme activity related to genetic mutations lead to an increased abundance and, crucially, altered ratios of specific VOCs being produced and released into the bloodstream and ultimately exhaled in the breath. This creates that unique potential signature for lung cancer that a sufficiently sensitive and selective eNose can learn to detect.
That's incredible. Before we dive deeper into the eNose tech specifically for cancer, there was even that fascinating study involving trained dogs, right? It almost sounds unbelievable, but it truly speaks volumes about the incredible power of the sense of scent. biological scent detection. And what about other high-tech approaches beyond e-noses that researchers have explored for breath analysis in lung cancer?
That's a great point, and it provides a vivid illustration of the sensitivity we're ultimately trying to achieve with electronic noses. Besides the advanced analytical lab techniques like GCMS, other methods like ion mobility spectrometers and Raman scattering have also been used for research purposes. These are highly sensitive laboratory instruments, but again, generally too bulky and expensive for widespread screening applications. But yes, there was indeed that truly remarkable study published in 2006 by McCulloch and colleagues that vividly highlights the unparalleled power of an evolved biological olfactory system. They showed that 5 trained dogs, ordinary household dogs trained specifically for this task, could sniff breath samples collected from 55 lung cancer subjects and distinguish them from samples from healthy controls with an absolutely astonishing 99% sensitivity and 99% specificity. The dogs were simply trained to indicate a positive sample by lying down in front of it. Their accuracy was phenomenal. It really serves as a compelling benchmark, demonstrating the potential for non-invasive detection through scent, and it's what eNose technology aspires to achieve in an accessible electronic format.
Okay, so how do we get our human-made noses to perform with that kind of precision, mimicking that incredible biological ability, or at least significantly surpassing the practicality and accessibility of traditional lab methods? What specific eNose technologies are showing the most promise for lung cancer detection right now?
Right. With the escalating demand for inexpensive, portable, and quick measurement systems, specifically for lung cancer screening, researchers have intensely focused on developing e-noses, incorporating various advanced sensor technologies. Let's look at some of the key examples highlighted in the research. Among the commercial systems that have been studied, the Cernose 320, which we mentioned earlier in the context of other applications, has been prominently used in lung cancer research. Machado et al., back in 2005, reported detecting lung cancer with 71.4% sensitivity and 91.9% specificity using this device, which utilizes an array of polymer carbon composite sensors that change resistance upon VOC exposure. Dragoneri et al. In 2009 even used the Cernose 320 to successfully discriminate lung cancer patients, not only from healthy controls, but also from patients with chronic obstructive pulmonary disease, or COPD. COPD is another common respiratory illness that shares some symptoms and risk factors, like smoking, with lung cancer, making differentiation important. This showed the system's ability to distinguish between different pathological states. Now, a critical confounding factor for lung cancer detection is, naturally, smoking history, as smoking vastly alters breath VOC profiles and is the primary risk factor for the disease. McWilliams et al. In 2015 tackled this head-on. They successfully used the Cernose 320 to differentiate the breath profiles of lung cancer patients from the breath of high-risk smokers, who didn't have cancer at the time, with 80% accuracy. This demonstrated that these systems, with appropriate training data and algorithms, can be robustly trained to distinguish even subtle differences that might otherwise mask a cancer signature within a high-risk population. Another commercially available system, the ENS MK3 eNose, which uses a hybrid sensor array combining MOS and electrochemical sensors, was also used by Tran et al. In 2010 for similar discrimination tasks in lung cancer studies. Then there are colorimetric sensor arrays. These typically consist of disposable cartridges patterned with, say, 36 different dots. Each dot contains chemically sensitive compounds, often metalloporphyrins or specialized dyes. The principle is quite elegant. The absorption of specific VOCs by these compounds leads to a detectable, distinct change in the color of each dot, creating a unique visual fingerprint or pattern for a given breath sample. Mazzone et al. In 2007 demonstrated lung cancer detection using such an array with 73.3% sensitivity and 72.4% specificity. They effectively differentiated cancer patients from various control groups, including people with idiopathic pulmonary fibrosis, another lung disease, and healthy subjects. They even further improved the accuracy by carefully incorporating confounding factors like smoking status, age, and sex into their analytical algorithms, highlighting the importance of considering patient demographics. Hewitt et al. In 2014 used a specific type of colorimetric sensor array incorporating gold nanorod MTPP polymers as the sensing materials and successfully detected 6 specific VOCs known to be associated with lung cancer with high sensitivity. Quartz crystal microbalance QCM arrays have also been extensively explored for lung cancer detection. Di Natale et al. In 2003 used an array of 8 QCM sensors, each coated with different metalloporphyrins. These compounds selectively bind to different VOCs, causing a tiny mass change on the quartz crystal, which in turn causes a measurable frequency shift. This method achieved an impressive 100% sensitivity and 94% specificity in their study, with an overall 90.3% accuracy in delineating 42 lung cancer subjects from 69 controls. D'Amico's et al. In 2010, further used a similar QCM-based eNose to discriminate lung cancer specifically from other lung diseases like COPD and bronchitis, achieving 93% sensitivity and 79% specificity. This again showed its ability to differentiate between challenging respiratory conditions based on breath profiles. However, some studies note that these QCM systems can sometimes face limitations, like relatively low long-term stability of the coatings and potential difficulties in consistently managing the deposition of metalloporphyrin-thin films for reliable large-scale array production. Surface acoustic wave, SLW sensors represent another powerful piezoelectric approach that's been applied to lung cancer. Shen et al. In 2005 and Wang et al. In 2009, utilized SAW-based eNoses to identify lung cancer by specifically focusing on detecting patterns among 11 and 5 key VOC biomarkers, respectively. These sensors, often coated with selective polymer layers, transduce the mass change from absorbed VOCs into a highly sensitive frequency shift. Wang et al. In 2012 even developed a hybrid system combining SAW-W sensors with MOS sensors and achieved 93.62% sensitivity and 83.37% selectivity, demonstrating a potential benefit of combining different sensing principles within one eNose device. Now, for developing smaller, more operable, and truly portable eNoses suitable for point-of-care use, researchers have increasingly focused on chimera-resistive sensors. As the name suggests, these rely on a measurable change in electrical resistance when gas molecules interact with the sensor material. Peng et al. In 2008 developed an array of single-walled carbon nanotubes, or CNTs. Each CNT sensor was coated with one of 10 different non-polymeric organic materials to provide diverse sensitivities. Their CNT-based eNose successfully discriminated between the VOC profiles of lung cancer patients and healthy subjects, and importantly, their results were further confirmed with the gold standard GCMS analysis. In 2011, used CNTs coated with specific alkane compounds, like tricosane and penidicane, to specifically detect known lung cancer biomarkers, like 1,4,2-valent-4-trimethylbenzene and decane. Additionally, combining CNTs with conductive polymer nanocomposites has been successfully explored by groups like Castro et al. And Chatterjee et al. To develop eNoses for detecting lung cancer biomarkers, aiming to harness the unique electrical properties of CNTs with the chemical tunability offered by polymers.
This sounds incredibly precise, especially using materials at the nanoscale, like carbon nanotubes. But I've heard about gold nanoparticles being used in other cutting-edge tech, using them in an eNose for cancer detection. That sounds like where it gets really interesting, blending advanced material science directly with biosensing for diagnostics.
It absolutely is, and this area represents some of the most groundbreaking and promising work in the field, particularly for cancer detection. Professor Hossam Haque's group, originally at the Technion in Israel, have done truly pioneering work utilizing gold nanoparticle GMP sensors. They typically use arrays of chimera-resistive sensors, but these sensors are embedded with incredibly tiny, just 5 nanometers or so, gold nanoparticles. And these nanoparticles are functionalized, meaning they're coated with different organic molecules, ligands, that act as the VOC receptors. The principle is elegant. When breath VOCs interact with these functionalized gold nanoparticles, they cause a measurable change in the electrical resistance of the sensor layer. This change can happen through various mechanisms, like modulating electron transfer between nanoparticles or affecting surface plasmon resonance. This change in resistance from each uniquely functionalized sensor in the array is then measured and processed, often using PCA or other machine learning algorithms, to generate that disease-specific pattern or fingerprint. Figure 6 in our source provides a nice schematic illustration of the architecture of such a GMP-based eNose system. Their achievements using this approach have been quite remarkable and have really pushed the boundaries of early, non-invasive cancer detection based on breath. Peng et al. From Haque's group in 2009 successfully distinguished the breath of patients with stage 3 and 4 lung cancer from that of healthy subjects. They did this even after using pre-concentration or dehumidification steps on the breath samples to enhance the signal clarity. Taking it a significant step further, Barash et al., also from Haque's group, in 2009 developed an 18 nanosensor array capable of detecting non-small cell lung cancer, even at early stages, stage 1 and 2. They achieved an astonishing 100% sensitivity and 75% specificity in their study, and critically, they did this without needing any pre-concentration of the breath samples. This demonstrates incredible potential for real-time point-of-care diagnostics, where sample processing is minimized. The work expanded even further, showcasing the potential for potentially screening for multiple types of cancer using breath. Peng et al. And again, in 2010, used a 14 nanosensor array that could distinguish not just lung cancer, but also breast cancer, colorectal cancer, and prostate cancer patients from healthy subjects, purely based on their distinct breath VOC profiles. This hints at the tantalizing possibility of a single eNose device potentially screening for multiple common cancers simultaneously. Peeled et al. In 2012, used an 18-sensor array comprising 16 gold nanoparticle sensors and 2 carbon nanotube sensors to discriminate between malignant cancerous and benign non-cancerous lung disease. And impressively, they could even differentiate between specific lung cancer subtypes, namely adenocarcinoma and squamous cell carcinoma, with 88% accuracy based on breath alone. This level of granular diagnostic detail could be invaluable for guiding personalized treatment plans right from the start. Finally, Nardiagmon et al. In 2016 combined the gold standard GCMS analysis with these nanosensor arrays specifically to supervise and monitor anti-cancer treatment response in lung cancer patients. This offers a potential non-invasive way to track therapeutic effectiveness over time, perhaps identifying early signs of recurrence or resistance to treatment simply through periodic breath tests. And beyond these powerful arrays, individual nanosensors are also being developed, aiming for hyperspecificity towards single, key lung cancer VOC biomarkers. For instance, highly sensitive detectors have been created specifically for toluene, a known lung cancer biomarker, using materials like platinum functionalized SNO2 nanofibers and palladium catalyst WO3 nanofibers. And Wu et al. In 2016 demonstrated a unique concept: a disposable tube containing 4 specialized sensors, 2 made of TiO2 and 2 of Ag and Ws, silver nanowires. This compact device was specifically designed to detect the lung cancer biomarker 2-propyl-1-pentanol, while simultaneously measuring humidity, temperature, and flow rate changes, ensuring a more comprehensive and reliable analysis within a simple, potentially single-use format. The key insight from all this research is the incredible breadth of scientific and engineering creativity being poured into tackling the challenge of early lung cancer detection via breath. From exploring diverse materials at the nanoscale to developing sophisticated pattern recognition algorithms, the eNose is being meticulously custom-built to discern the most subtle, yet potentially critical, chemical whispers of lung cancer. It truly offers a tangible pathway towards earlier detection that could dramatically improve patient outcomes for this devastating disease.
It's absolutely clear that the eNose is an incredibly powerful and versatile tool. The potential across different diseases, from diabetes monitoring to early cancer detection, is just astonishing. But given all this incredible progress we've discussed, where do eNoses stand today, really? What's realistically on the horizon? And what challenges still stand in the way before this technology becomes a standard, everyday part of our medical toolkit, something you might encounter at your GP's office or even use at home?
You're right to ask that, to ground the excitement in the current reality. Since the initial discovery that VOCs in breath could correlate with disease states, intensive research has certainly focused on detecting specific biomarker VOCs and understanding their link to various conditions. And we've definitely seen significant methodological and material improvements over the years. These have led to the development of faster, lower cost, and more portable eNose devices compared to the early prototypes. However, there's still a gap. Our current knowledge and technology allows to effectively mimic the mammalian nose in many respects, yes, but it's generally not yet sophisticated or robust enough to universally replace established diagnostic methods across all scenarios. Existing eNose systems are still largely application-specific. That means they are typically optimized for detecting one particular disease or maybe a narrow set of related conditions rather than being truly universal diagnostic tools. This is often due to inherent limitations that still need to be fully overcome. Things like consistently achieving high sensitivity and high selectivity simultaneously across a broader range of relevant biomarkers, especially in the presence of confounders. Or maintaining that high performance while achieving true portability and low power consumption. Or ensuring rapid analysis speed under diverse environmental conditions outside of a controlled lab. And as a result, most of the devices described in the literature, unfortunately, are still prototypes or research tools, and quite far from being widely commercially available, validated, and regulated products ready for routine clinical use.
But the demand, the need for these smart sniffers is clearly growing, isn't it? The potential benefits seem far too great to ignore, especially for diseases with such a massive global impact like diabetes and lung cancer.
Absolutely. The demand for eNoses, both in clinical research settings and potentially for other fields like environmental monitoring or food safety, continues to increase year by year. This demand is fundamentally driven by that profound unmet need for better, faster, cheaper, and especially non-invasive diagnostics. And so far, The specific large-scale clinical validation studies for diseases like diabetes and lung cancer using e-noses are still relatively few in number compared to the potential scope. This really suggests there's vast, untapped potential in a burgeoning field for much more research development and, crucially, clinical translation in this area. It's truly a frontier in medical technology with huge possibilities ahead. Envisioning the future. With the ongoing and frankly rapid advancements we're seeing in the sensing device materials, microelectronics fabrication, and signal processing algorithms, e-nose systems are undoubtedly poised to become even smaller, more energy efficient, and capable of much faster data processing. Ultimately, the goal is to provide reliable, real-time results directly at the point of care, whether that's a doctor's office, pharmacy, or even in this patient's home.
So these won't just be clinic devices that we might see in hospitals someday. You're talking about something far more integrated into our daily lives, something potentially truly ubiquitous.
Precisely. The long-term vision extends far beyond just the traditional clinical setting. You can imagine these sophisticated sensing tools fitting seamlessly into advanced integrated systems, perhaps even embedded within human-like robots designed for elder care or remote health monitoring, constantly checking vital signs and health status through breath. More tangibly, and perhaps sooner, envision them integrating directly into our mobile technology for personal use, allowing for, say, daily monitoring of disease progression for chronic conditions like asthma or diabetes, or early detection of infections or illness flare-ups, or even simply tracking your general wellness and metabolic state right from your smartphone or maybe a wearable device. Think of a smart mirror in your bathroom that analyzes your breath each morning for health indicators, or a simple handheld device that monitors glucose levels with a quick, painless exhale instead of a finger prick. The potential for truly personalized, proactive healthcare is enormous. It's about putting powerful diagnostics out of the specialized lab and into your everyday life, empowering individuals to take more control of their health. Fundamentally, e-nose systems have the capabilities to detect diseases at incredibly early stages, often before symptoms even appear. This will be profoundly helpful to patients, both psychologically reducing anxiety associated with testing and late diagnoses and economically. Early detection almost always means earlier intervention, which often leads to better treatment outcomes, less invasive and costly treatments, and significantly reduced overall healthcare costs in the long term. I genuinely believe that in a matter of time, we will see the e-nose emerge as a leading non-invasive technology for the early diagnosis of many different diseases, fundamentally transforming how we approach healthcare and wellness monitoring worldwide. That said, we absolutely must acknowledge the key remaining hurdles that need to be overcome to get there. As I mentioned, most devices reported in research are still at the prototype stage, far from being robust commercial products ready for widespread consumer or clinical use. This is largely due to ongoing challenges in further miniaturization, maintaining high performance while shrinking the device size and cost. Also, achieving rigorous and universal calibration standards that work reliably across diverse populations and environments is critical. And finally, developing processes for large-scale, cost-effective manufacturing without compromising the quality, reliability, or sensitivity of these complex devices remains a significant engineering and logistical challenge. These are the crucial engineering, manufacturing, regulatory, and clinical validation challenges that need to be systematically solved to bring this truly transformative vision of breath diagnostics to full fruition.
It really does sound like we're on the cusp of a genuine diagnostic revolution, though. All thanks to finally learning how to interpret these hidden, complex messages carried in something as simple as our breath. The journey from just a few anecdotal observations centuries ago to sophisticated nanotechnology, powerful AI, and integrated sensor systems today is, well, breathtaking in itself. And the implications for human health feel truly profound. What an incredible deep dive that was into the world of the e-nose. We've journeyed from understanding the basics that our breath contains thousands of these volatile organic compounds, tiny chemical messengers, to exploring this sophisticated sensor arrays made of advanced materials, and the complex machine learning algorithms that are learning to interpret their secret language, picking out patterns associated with disease. We've seen how this non-invasive technology is offering real, tangible new hope for the early detection and ongoing monitoring of incredibly challenging diseases like diabetes and lung cancer, from detecting elevated acetone levels indicating metabolic shifts to identifying complex odor prints of cancer using incredibly precise gold nanoparticles. It's truly a testament to human ingenuity mimicking, and maybe one day surpassing, nature's own designs.
I think what truly stands out here is the profound potential for a paradigm shift in how we approach diagnostics in healthcare. Moving away from often uncomfortable, time-consuming, expensive, and sometimes invasive traditional methods towards a future where a simple, quick, painless breath could provide critical, actionable health insights. This wouldn't just be more convenient, it would fundamentally make screening more accessible to millions, perhaps billions, of people globally, removing many existing barriers to early care. And ultimately, it has the very real power to save countless lives through earlier intervention, better disease management, and more personalized approaches to health. It's a potential leap towards more humane, more efficient, and much more proactive medicine for everyone.
So, as you go about your day-to-day, maybe take a moment to just consider the silent, invisible narrative of your own breath. What stories might it be telling about you right now, about your health, your metabolism, your recent activities, your environment stories that we're only just beginning to learn how to hear and understand? And how might this rapidly evolving technology change our very definition of a wellness check or a routine medical examination in the decades to come? Could proactive health monitoring become a seamless, effortless part of our daily lives? The future of diagnostics might just be quite literally a breath away.